In today's episode, we are going over an evidence-based guide to physical therapy after meniscus repair. Let's get it rolling. So, Dan, what is the problem, right? So, imagine you're a physical therapist. You're coming in Monday morning, 7 a.m., and your first patient is a meniscus repair, right? They come through the door, and the doctor's protocol says this toe touch weight bearing for the first 4 weeks, followed by partial weight bearing for 2 weeks using a brace or locking that knee in full extension. And then you start weight bearing as tolerated at week 6. You're going to be locked in full extension. And then at week 8, you can start weight bearing as tolerated without the brace. In terms of range of motion, week 0 to 6, you're only allowed to flex the knee to 90 degrees. Week 6 to 8, your knee flexion is only to 135 degrees. Okay, very conservative protocol. Let's say you finish up with that patient, 8 a.m., next patient comes in. It's actually from a different doctor, but same surgery. It's a meniscus repair. You take a look at the surgeon's protocol, and it says this: no restrictions, right? So this is actually pretty funny, but it's pretty true. So I see this all the time. You get some docs that are extremely conservative when it comes to meniscus repair, and you get some docs that are the opposite, right? So obviously that's a bit of a problem. And as physical therapists, we're trying to figure out what's actually accurate, right? We have a lot of questions that need answering. So when should we be starting physical therapy with these patients? When is it appropriate to start weight bearing? What are the range of motion restrictions? What does the literature say about range of motion and what's safe and what's not, right? How about return to sport? Because I'll tell you what, these protocols are all over the place. I've seen protocols that say return back at 3 months, and I've seen some that are 6+ months, right? So what gives? What's going to be a good answer for these patients? And the other part is that should the start of weight bearing as well as range of motion vary based on the person or their particular presentation, right? Because it probably should. So we're going to do a summary of what the literature is suggesting, right? So when do we start our weight bearing, right? Are we going to disrupt the repaired meniscus if we weight bear too early? Should we be wearing a brace? When should we start range of motion? And how far should we push it? Are we going to be damaging the meniscus repair if we do too much too soon, right? What are the rehab timelines that are evidence-based? And lastly, when should we return to sport? Lastly, I just want to try to give you some practical recommendations, right? So let's use our brain a little bit when we go over this, and then we can critically reason with the patients we're working with, because they're going to be different types of meniscal repairs and different people you're going to be working with that probably influence the speed at which you go through a lot of these things, right? So what's the difference if you're working with a radial tear versus a vertical tear, right? What about the location of the tear? Is it medial or lateral, right? Is it going to be in the front of the meniscus or the back or the posterior part of the meniscus? Are you dealing with an acute injury or more of a chronic injury? Is it a complex tear, right? Or is it a bucket handle tear? And lastly, what is the patient's age? Because it probably does play a role, at least with rehabilitation, right? And the last thing I'm going to do is I'm going to show you exactly what I do with my patients. One of the things I think is lacking in the physical therapy community is folks that have a lot of experience that are actually sharing what they're doing on a regular basis from A to Z, right? So I'm going to show you exactly how I rehabilitated a power lifter of mine. So an in-depth case study of Chrissy Pracky, who's a 2-time national champion. Show you how we started, how we progressed, and how we got back to, winning a national record or getting a national championship, right? So welcome to the Fitness Pain-Free Show. This is where we help coaches and physical therapists like you get your patients out of pain and back to training. My name is Dan Pope. I'm a physical therapist, coach, personal trainer, and meathead. I love fitness. I have my dream job as a physical therapist, coach, business owner, and educator for several decades now. I want to help share some of my knowledge to help you get to a place where you're happy with your career and you're kicking butt in the clinic, right? I want to say sorry in advance for this bait and switch. So I've just taken this statement from a research study I'll talk about in a second. Basically, they say there's a lack of consensus regarding the optimal post-operative protocol following meniscus repair. At present, there is a paucity of evidence to support one best practice, and there's a high degree of variability among post-operative rehabilitation programs. Additional studies are needed to better clarify the interplay between tear type, repair method, and optimal rehabilitation program. So I took the majority of information from this article here from the British Journal of Sports Medicine. And this is called Rehabilitation Following Meniscal Repair, a systematic review. What's kind of cool is one of the authors is Arun Ramappa, who's a local surgeon in the Boston area, which I really like and we refer to quite a bit, right? I know this is 2018 study, right? So it's maybe not the most up to date, but here's the thing. If you start looking through the literature, the newest article I could find was in 2022, and I actually cite this paper quite a bit. But this paper, in my opinion, didn't do as good a job as this paper did. And they used almost all the same references. And unfortunately, it seems like somewhere between 2005 to 2010 up until present, we just stopped doing research on meniscus repairs, which is a bit unfortunate because obviously there's a lot of questions that need to be answered, and we don't have these answers. And it seems like in the past 15 years, we haven't done much to try to figure these out, right? But let's try to rationalize some of this so you can have some good takeaways. And before we get started, I want you to get you up to date on meniscus pathology. So I have a free meniscus pathology cheat sheet. It's evidence-based. I'm going to leave a link in the bio so you can check it out, right? So a lot of what we're going to talk about today is going to rely on you understanding some of this, right? This is evidence-based. Like I said, we're going to go over prevalence of meniscus tears. We're going to go over the anatomy of the meniscus and meniscal tears. We're going to go over common mechanisms of injury, clinical presentation, evaluation and diagnosis, treatment strategies, as well as surgical considerations. Once again, I'll leave a link in the show notes. It is 100% free. We'll get you up to speed so the rest of this presentation makes more sense. So this is actually part 2 of this series on meniscus repair. So if you missed part 1, I'll leave a link in the show notes. And also, if you're watching this on YouTube, I'll leave a link above. So you go ahead and click on that. If you haven't listened to part 1 first, and I definitely recommend going back and checking it out. Okay, let's get moving on. So what about catering a rehabilitation protocol to the individual and to the type of tear that they have, right? Because that kind of makes sense. There's all different types of tears, right? Especially those radial tears are especially concerning. We'll talk about them a little bit later. But this was a cool study by Kokabe et al. 2004. I apologize, probably butchered that. And they showed excellent results using rehabilitation guidelines specific to the tear's characteristics, right? So in anterior, posterior, longitudinal tears, less than 3 centimeters, so a smaller tear, they used weight bearing as tolerated without a brace immediately, and range of motion progressed to 125 degrees between 3 and 6 weeks, right? In tears that were greater than 3 centimeters, weight bearing was allowed in a locked brace, and then range of motion was limited to 0 to 125 degrees until 6 or 8 weeks, and then return to sport was allowed after 3 months. In complex and radial tears, they were required to wear a brace, they were weight bearing as tolerated, and they ranged from 0 to 125 degrees for 6 to 8 weeks, and they returned to sport between 4 and 5 months. So the idea is that in small tears that are vertical, you're going to be able to do more sooner. And then for radial tears or complex tears or larger tears, you wait a little bit longer to ramp up all of these things. So weight bearing, range of motion, so on and so forth. And in all of these groups, they had a very good outcome, right? So it does make sense to try to cater your rehab to the individual. It's just that we're not sure, because if you applied the same exact rehab protocol to all of these meniscal tears, you might have had the same result, right? So they didn't have control groups in order to figure that out. So guys, if you like what you're learning about so far, then I want you to go and check out the Fitness Pain-Free Mini Course. So I made a mini course. It's absolutely free. That's the next logical step if you want to learn more from me. So in the course, we go over 5 lessons. That first lesson is how traditional schooling has failed us, right? So schooling is phenomenal from a physical therapy perspective, but doesn't really teach you how to work with high-level athletes in the fitness world, right? Doesn't always teach you how to do the lifts appropriately. Doesn't teach you about progressions and regressions of common lifts within the gym. Doesn't teach you how to program normally, how to write rehab programs, or how to write injury prevention programs for these folks. Next thing we go over, 7 reasons why people get hurt in the gym, 4 simple steps to getting your clients out of pain, how to build the career of your dreams and earn the respect of your community. It's all well and good if you know exactly how to work with folks within the gym. But if you can't get these folks through the door on a regular basis, then you're simply not going to be living the dream that you want to, because you can't get the patients through the door that you want to work with. Okay, so I'll show you how to do that.
And lastly, we'll talk a little bit about the fitness pain-free certification, right? So I'll leave a link in the show notes. I definitely recommend checking this out. Once you sign up for the Fitness Pain-Free Mini Course, you will be automatically placed in the waitlist for the Fitness Pain-Free certification. Now, the Fitness Pain-Free certification is the course, the certification that I wish I had as a new grad that fills in all the gaps in knowledge that you don't get in physical therapy school. So, A, you'll gain complete confidence working with injuries in the strength and fitness world. You'll learn optimal technique for both health and performance from myself and some of the best coaches in the world. You'll master programming for rehabilitation and injury prevention. Have fun while earning a whole bunch of physical therapy and physical therapy assistant credits. You have 31.5 of those. You'll also gain NSCA credits as well as CrossFit credits if you need those. This is the equivalent of a university education in working with injuries in the weight room. I really believe that. I've been adding to this thing over the past 5 or 6 years. It's massive, a ton of phenomenal information. And lastly, the biggest goal is just to fill your day with the patients you love working with and building the respect and admiration of the communities you love working with. So I'll leave a link in the show notes. Sign up for the Fitness Pain-Free Mini Course. The certification is open 4 times per year for 1 week to enroll into. If you're on the wait list by signing up for the Fitness Pain-Free Mini Course, I'll alert you when that next enrollment period is open and you can get started. Let's get back to the show now.
The next really important consideration is that should we treat radial tears differently than longitudinal tears, right? Because if you have a radial tear and you weight bear on it, theoretically, you're going to pull that tear apart. And if you have a longitudinal tear, if you weight bear on it, it actually pushes that tear back together, right? So keep in mind that most of the research on meniscal repair, rehabilitation are on longitudinal tears, right? However, a few papers are looking at radial tears. So Hackler et al. In 2008 had post-op meniscal repairs that were radial in nature. They had immobilization and non-weight bearing for 6 to 8 weeks. So that's a large period of time. And Choi et al. In 2010 had toe touch weight bearing was recommended for 6 weeks, followed by a gradual increase of weight bearing over the following 4 weeks. So the Choi paper was a little bit faster than the Hackler paper. They both had generally good outcomes. Just keep in mind that if you're trying to repair a radial tear, oftentimes these aren't as successful, and this is probably due to the healing capacity of the meniscus. So if you have a tear in the periphery of the meniscus, usually heals a bit better. And if it's towards the inside, it typically doesn't heal quite as well, right? If you have a radial tear, it tends to go through these zones, right? So generally, the radial tears don't heal quite as well normally. So we probably want to go a little slower with these, right? And I'll tell you what, so if you have a radial tear, you can kind of follow the strategy in these papers, but I don't know that we know what's best for radial tears yet. It's not like they did a study and they found that they had terrible results, and they did another study and they had great results. Both these studies showed they had decent results, but we're not really sure what's best, right? Do keep in mind that in radial tears, weight bearing can separate the meniscus repair, so we probably want to be a little bit slower with these folks. So what about return to sport times after meniscus repair? So the majority of studies recommend return to sport somewhere between 3 and 6 months. And I have to tell you, at 3 months after meniscal repair, that's super fast, right? I don't feel comfortable doing that based on my experience, especially if you have a more conservative doctor. Let's say you start weight bearing as tolerated by the 6-week mark and you were restricting range of motion up until then. You only have 6 weeks to get someone completely ready to run, jump, change direction, do everything that's required with a given sport. I think 3 months is really, really fast, right? And I think the 6 months is probably a little bit more reasonable. But again, that's my personal opinion, right? This study by Logan et al. In 2009 gave us a little bit of feedback on when elite level athletes return back to sport after meniscal repair, right? So I had 45 repairs. These were in elite athletes, which the definition was professional or amateur that competed nationally or internationally. And the majority of these athletes were in rugby, but they also had netball, basketball, soccer, touch football, hockey, and some other sports, right? And they had a minimum of 5 years follow-up, which is pretty good. So they're going to check and see how they're doing years after this repair, as opposed to, let's say, 6 months to a year. They have more data. And the good thing is that 81% return to sports, and that's pretty dang good. The other thing that's important is that the vast majority return back at their prior sporting level. So a big issue with return to sports is that if you return back to sport, obviously that's good, but how often are you returning back to the same level? for a lot of athletes, if you're playing a professional sport, if you can't get back to the same level you were playing at previously, then you're really not that helpful for the organization, right? So you can argue that that surgery was not a success. But 81% of these athletes returned to sport, and the vast majority got back to their prior sporting level, which is a good thing, right? The mean return to sport was 5.6 months. And this ranged between 3 and 8 months for an isolated meniscal tear and 11.8 months for ACL reconstruction with meniscal repair. We'll talk a little bit more about this later, but suffice to say, if you get the ACL done with a meniscus, it tends to be a longer rehab time. And what I will say is that this 5.6 months makes me a little more comfortable as a clinician. That's what I tend to see. I see folks getting back closer to that 6+ month mark, right? And I think that's more realistic as opposed to 3 months. I think if you tell an athlete they can get back at 3 months, which I have certainly seen, oftentimes they're left very frustrated because they get back, they're hurting, they're not performing well, sometimes get re-injured, and that's obviously no bueno, right? So I think it's better to set the expectation that it might take closer to 6 months. If you're feeling phenomenal, maybe return a little bit sooner, but I don't want to push it, right? And give that athlete the idea they're going to be able to get back sooner, and then they get disappointed, right? This was also interesting because we're going to talk about this a little bit later, but age, size of the tear, and location of the tear were not associated with a higher failure rate, right? So we just made this big hubbub about if you have an individual, you have to treat them like an individual. But it doesn't seem like, at least in this study, it made a difference, right? So if you had a bigger tear, if you were older or younger, right? If you had a different location of the tear, medial versus lateral, anterior versus posterior, didn't seem to make a difference, at least with failure rates. And medial meniscal repairs were significantly more likely to fail than lateral meniscal repairs, with a failure rate of 36.4% and 5.6%, right? So take back what I just said, right? Because the medial versus lateral tear obviously was significant. So at least in my mind, I start to think, well, do we have to be a little bit more careful with the medial repairs just because they had a more likely or higher likelihood of having a re-tear over the course of time? So this image is taken from a paper from Kalana et al. In 2022. And what they're trying to do is give you a return to sport time that's going to be related to the degree of damage that you had from your meniscal tear and subsequent repair, right? So use this Tegner scale to quantify how bad the tear was. So if you had a stable tear, and that would be a longitudinal vertical tear, right? If you had a Tegner 0 to 3, you can return back in 2 months, Tegner 4 to 5, 3 months, Tegner 6 to 10, 5 to 6 months, right? And if you had an unstable tear, so this would be radial tears or root lesions, a Tegner 0 to 3 would be a return to sport at 3 months. A Tegner 4 to 5 would be return to sport at 6 months. And a Tegner 6 to 10 would be return to sport at 9 months, right? And I think this does make a little bit of sense, right? So if you have a really bad, unstable tear, then we probably have to go a bit slower. It takes a little longer for you to get back to sport, right? If you have a really small tear and it was repaired very easily, you're having a very good rehab, maybe we send these folks back to sport a little bit sooner, right? Keep in mind the paper I talked about previously actually showed that this wasn't as important as we might think. However, I do think this is probably reasonable. Big tears, unstable tears go slower. Small tears, very stable tears, longitudinal tears, and go a little faster. So what about concomitant pathology? So basically, if you get a meniscal tear, but you also suffer some other type of injury with it, the most common one to suffer with the meniscus is usually the ACL, right? And this study by Wasserstein et al. In 2013 showed a patient cohort with concomitant ACL reconstruction was found to have a meniscal reoperation rate of 9.7%. However, in folks that didn't have the ACL reconstruction because they didn't damage it, they had a 16.7% rate of revision repairs after meniscus repair, right? So it's actually pretty interesting. So if you have an ACL reconstruction plus a meniscus repair, you're less likely to have a re-tear of the meniscus, right? If you have the meniscus tear alone and repair alone, you're more likely to have a re-tear revision, right? In an ACL deficient knee, meniscal repairs are prone to failure due to persistent mechanical stresses on the tissue. So let's say that you tear a meniscus and you tear your ACL and you decide not to get the ACL reconstructed, but you get the meniscus repaired, you're more likely to have future injuries to the knee, right? And it's kind of interesting because we're not sure why patients that get ACL reconstruction have better outcomes with their meniscus. But the thought is that maybe there's better blood flow to the area and the meniscus heals a little bit better, right? The other piece is that if you get an ACL reconstruction, chances are you're going to have a more in-depth rehabilitation and you're going to return to sport a little bit later. So maybe that's the reason why the meniscus does a little bit better. At the end of the day, we don't really know. And the other piece is that if you have an ACL reconstruction, then yes, we're thinking about the meniscus as we rehabilitate. But the thing that's going to hold you back is going to be the ACL reconstruction, and the return to sport is going to be based around the ACL reconstruction and not just the meniscus. So if you have this concomitant pathology, you have to respect all aspects of the knee that was damaged initially and then afterwards repaired, right? So what are some other important factors that we should probably consider with meniscus repair? And here's the thing. A lot of this is based on critical reasoning. It's not evidence-based. We don't have thorough research about this just yet, but it does make sense. If you have an older athlete, then maybe you want to delay higher level activities for them. If it's a younger person, then maybe they can go a little bit quicker. They probably do heal a little bit faster, right? The other piece is it may depend on the type of tear they have, right? So if you have an acute tear, traumatic tear, we know those tend to do better when we repair them. If you have a chronic tear, you try to repair that, we know that that doesn't really do as well as an acute tear. But the other piece is that from a rehab perspective, maybe we slow things down a little bit just because we know they tend not to do quite as well, right? The location of the tear, probably going to be important. So if we think about a red zone tear, lots of blood flow, probably heals pretty dang good versus a repair that extends into that red-white zone or into that white-white zone. Maybe we have to delay those folks a little bit because the blood supply is not quite as good. So it might not heal quite as well, right? Maybe we have to think about the location of the tear in the front of the joint versus the back side of the joint, right? So if you have an anterior tear versus a posterior tear, it may influence the exercise that you use or the depth of knee bending during exercises. And I apologize in advance. Again, if you're watching this, then you'll see exactly what I'm doing right now. But if you're listening to this, you won't. I'll try to describe this, but at some point, check out YouTube. It'll help to get you to understand this concept. So I have a knee right here. So let's say I'm locked out into full extension. So if I look at my tibiofemoral joint, between the femur and the tibia, then the front portion of the joint is taking a little bit more stress. As I bend the knee further and further and further and further, I actually take a little bit more stress to the posterior aspect of the knee, particularly the posterior medial aspect, right? So if I'm dealing with an athlete that has a posterior medial tear, which is actually pretty common, I might have to be a little bit careful with my range of motion. Quick story I'll share is I had a softball athlete, and she had a posterior medial meniscus repair. And her surgeon said that she can get back at 3 months, right? The other piece is that she's a catcher, right? So she is sitting in deep knee flexion as part of her sport. And I just knew based on the location of that tear, right? And the position that she's going to have to be in, that 3 months seemed a little unrealistic. But I'll tell you what, this ended up being a bit of an argument because the surgeon was like, nah, you'll be fine. Don't worry about it. The athlete was like, I want to get back as soon as possible. I was saying, hey, let's pump the brakes. That's really quick. And she ended up pushing the envelope a little bit. She got particularly sore. She returned back to sport. She ended up re-injuring her meniscus and getting surgery again. And I'm not trying to scare you or evoke a ton of fear, but we do have to be a little cautious with the location of the tear and what the athlete is trying to get back to. So at least in my mind, that 3-month mark is really tough to get back, I think, right? Especially for someone who's trying to get back to deep ranges of knee flexion range of motion and sit there over the course of an entire game, right? So I think from a critical reasoning perspective, if you have a catcher that's going back to sport and they have a tear to the posterior medial part of the meniscus, we probably can't get back really quickly. It's probably going to take a little bit more time, all right? So what are our takeaways from this today? So first and foremost, I apologize here, but there's a lot that we don't know. And I think it's important that you just understand that, right? So I can't tell you there's black and white guidelines for this. There really are not, and there really needs to be more research in the future. I'm going to give you my takeaways based on what I read in the research. So in terms of weight bearing and when you can start, early weight bearing, especially for those longitudinal tears, right? Radial, not so much, is probably fine and maybe optimal. The big issue here is that if you have a meniscal repair, your quad's going to get really weak, right? The problem is that if you delay weight bearing for a long period of time and you delay range of motion for a long period of time, that's going to delay the entire process. It's going to give you more weakness, more atrophy, and it's going to be harder to come back, right? So if you have someone that's delayed from the beginning, that's going to delay all of their progress in the long term, right? We know that's a big problem. So it may be better to have earlier weight bearing from that perspective, right? So how about ranging the knee? Early is probably fine, again, for those longitudinal tears, and it may depend on the type of tear. So if you have a tear on the posterior medial aspect, we do a whole bunch of end range knee flexion right away. Is that going to put too much stress on the area? I don't know, but maybe just because our knowledge of deep knee flexion putting more stress on that area, right? And lastly, this is often dependent on the surgeon, right? And my recommendation for you is to not go against the surgeon. So if you go against what the surgeon recommends and they find out, chances are they're not going to refer more patients to you. They get really freaked out by physical therapists going too fast, for sure, right? The other piece, you may start to assume liability. So let's say this thing re-tears and you were the one that was pretty aggressive in the beginning. They may start to put the blame on you, right? What we do at Champion Physical Therapy and Performance is we just find good surgeons that we really like and trust. And then when they send us a patient, right, and we think that they're being a little conservative, we'll just, send them a text or an email and say, hey, doc, I'm concerned this person is going to get too stiff. I'm concerned this person is going to get too weak. Can we start a little bit sooner? And usually they trust us and allow us to make decisions that are best for the patient, right? So at the end of the day, don't go against your surgeons, right? Don't burn your bridges. But what I will say is that find good surgeons that trust you, ask smart questions, and do what's best for the patient, right? Your rehabilitation should probably depend on the individual, right? So most certainly tear types. So you have a radial tear or complex tear, you probably need to go slower, okay? If you have a vertical tear, it changes the game because that hoop stress is actually going to approximate those surgical sites. It's going to decrease stress on that meniscal repair, whereas with a radial tear, it doesn't do that, all right? So it definitely changes how fast you progress. Let's say you have an acute tear versus a chronic tear. If you have that acute tear, probably going to heal a little bit better than a chronic tear. So maybe we go a little slower in that chronic. That location is probably going to be relevant, right? Remember we talked a little bit about the medial versus lateral tears. Those medial tears have a higher likelihood of re-tearing, so maybe go a little slower with those. If you have a really big tear, so greater than 3 centimeters, maybe we slow it down. If it's smaller, maybe go a little faster, return to sport a little faster. And lastly, you have to respect the concomitant pathology. If we have an ACL reconstruction, seems like that's going to be good for the meniscal repair, but it also means you're going to be delaying your return to sport by quite a bit more time. Our research shows that these folks tend to take a little more time to get back. So these are the evidence-based suggestions from Kalana et al. In 2022. They recommended that if hoop tensile stress effect is preserved, so this would be in vertical tears, then an accelerated rehabilitation program may be suggested. So maybe you'll start with partial weight bearing around 20 kilograms, and range of motion is limited to 90 degrees for the first 4 weeks, and then weight bearing as tolerated afterwards, right? Seems to be reasonable. However, when circumferential hoop fibers are disrupted, so think about those radial tears, then restricted rehabilitation protocols may be recommended. So no weight bearing for the first 6 weeks after surgery, and range of motion could be limited to 90 degrees, right? So at the end of this entire presentation, I can't give you concrete answers, but if you want to have a little bit of evidence suggested informed decision making, you can take these, right? Use them with your patients. So here's what I want you to do next, guys. I made an entire fitness pain-free show episode called When to Have Surgery for a Torn Meniscus. If you're a physical therapist, you're often trying to make a decision of whether or not you want to refer a patient to the surgeon and have them make the best decision for the patient, right? So when do you need surgery? Should you get a meniscectomy? Should you get a meniscus repair? Should you try conservative care? At what point do you refer to the doctor after conservative care? I answer all of these questions in this podcast. So go ahead and click on this link above, and you can check out when to have surgery for a torn meniscus. So lastly, I just want to say thank you so much for your support. You truly do allow me to do what I love for a living. If you're watching this on YouTube, please hit that like button, comment, and subscribe. I'd love to hear your thoughts about this episode. If you are listening or watching via podcast, consider leaving me a positive rating and review. Helps out the algorithm tremendously and allows me to continue making episodes like this in the future. And lastly, if you want to go that extra step in supporting me further, consider subscribing to Fitness Pain-Free Insiders. It's a comprehensive educational resource and toolkit for the fitness and rehab professionals. Think Netflix, but for trainers and physical therapists. It's got premium content from me. I update this monthly and have been doing it for the past 5 years. It's over 100 webinars, ebooks, and complete guides. A private Facebook group to have questions answered by me. You can decide upcoming podcast topics. Get started for just $1. After that, it's $12.99 a month. You can cancel anytime. So head over to fitnesspainfree.com, click on the programs link, and click on Fitness Pain-Free Insiders online library. One of the lessons in there is exercise prescription for knee pain, where we go over exercise prescription in depth for meniscus injuries. I think you'll definitely learn a bunch with that. And lastly, if you want to check out the references, I'll leave them in the show notes, right? If there are any good papers you want to notify me of, please let me know, right? And that's it for today. Thanks again.